Afternoon, I'm Karen Hershey, and thanks for joining us for our live webcast with world-renowned eye surgeon Dr. Gulani. He's also founder of the Gulani Vision Institute right here in Jacksonville. And today we're going to be talking about surgical options for a degenerative eye disease called keratoconus. The National Keratoconus Foundation says this disease affects 2,000 Americans each year, and it's usually first diagnosed when someone is in their teens. Dr. Glani has returned after teaching at the National Conference for Eye Surgeons held in Chicago last week, and he's here to talk to us about some recent breakthrough technologies involving keratoconus. So first of all, right off the top, what is keratoconus and what are the symptoms?
Keratoconus, Karen, is when the eyeball, we all have a clear cornea, as you can see, and the cornea is supposed to be dome-shaped in normal people. When that cornea becomes cone-shaped instead of dome-shaped, that's when the cornea is called kerato, meaning cornea, conus, like a cone. And then as you can imagine, I have some graphics we'll show. As you can imagine then, the cornea cannot, the glasses cannot correct the vision, and contact lenses cannot help the vision too, because they're kind of straddling this abnormally cone-shaped cornea. So keratoconus is a condition where the refractive error of the vision gets so bad because of the distorted shape of the cornea and makes it impractical for these patients to wear glasses or contacts.
Now you see patients from all over the world that have keratoconus. You offer a wide range of different surgical options for keratoconus. So what are the different treatments available to people?
For keratoconus, once they've tried glasses and contacts and they've exhausted all those treatments, there are various modalities nowadays, and some still in the pipeline that we've had the privilege to evaluate and see. But very popular nowadays is the intact surgery, where we're putting in tiny braces, if you may, into the cornea. Remember, by the textbook, the real treatment for keratoconus, the definitive treatment, has always been a transplant. But transplant is still an invasive surgery where replacing the whole cornea. That can still be done, but I would reserve that as the last resort. So to deal with the conus, as I said, because the cornea is cone-shaped, you want to somehow give it a shape so it becomes more dome-shaped, so they can wear contacts, glasses, and get about their lives. Now, the way I like to discuss it with patients is, I tell a patient with keratoconus, it's like as if you're 11 feet tall. Now, you cannot go to the mall and pick up a suit to go to a party tonight. So come on over here, let me put some braces in you, make you somewhere close to 6 feet tall. I don't know how close, whether you'll be 5 feet 8 or 6 feet 4. But that's what Intact does. It takes you in the right direction towards the dome, but you cannot predict how exact to the dome. So when you put these braces into the cornea, pretty much the cornea is now more towards normal. So these people, I tell them, now you're close to 6 feet, you'll find a suit in the mall and you can wear that. It won't fit you perfect yet, all right? But you can get away with it.
But you're getting close to it.
Exactly.
Okay.
That's
now we mentioned this Intact corneal implants. And this is, from what I understand, one way to avoid a cornea transplant.
Mm-hmm.
So can you explain a little bit more about what these Intacts are, and
Sure.
are they painful?
No, not at all. Actually, we have some patients here with it. So if you see this, you can practically see the Intacts. I will actually brought some Intacts to show the viewers too. I'll put them on the palm of my hand.
Oh, they're so small.
They're extremely small. So if you see over here, we can see the rings and how the rings go. I'll show you a graphic video too, but these are actually how small the rings are.
They're tiny, and they're very thin. I don't know if you guys can see them on the hand, but they're very, very small.
Extremely small. And these rings are kind of put into a channel into the cornea, and then they stay there and kind of bring the cornea down from a cone to a dome, and the patient can see much better.
Now, can you feel that? Because what are they made out of?
They're made of it's called an acrylate material, PMMA,
Okay.
but you cannot feel it because once it's in your corneal channel, you don't really feel it.
So you can't feel it at all, even though
No.
it looks like it.
No.
And you have an actual surgery?
I have an
video?
animation that I brought so our viewers can actually see.
How long does a surgery like this take?
Approximately 7 to 10 minutes, and it's done with numbing drops, so the patient's pretty much mildly sedated, and you can perform the surgery.
Do you do one eye at a time, or?
Always one eye at a time. That's a safety protocol for Intacts, and also because each cone is so different, you get to learn from that eye how much more better you can make the other eye.
Okay.
So I'm going to now show the video animation of this Intact surgery. Just make it.
Do you have to make a cut?
You make a small channel with a diamond instrument,
Okay.
and then you can kind of enter the cornea. I'll show you everything, and we can see it pretty much right here. So here we go.
Well, only like 7 to 10 minutes seems pretty amazing.
Here we go.
Okay.
So that's the intact surgery being shown in animation. As you can see here, that's the channel being created, and that's the ring which will now go into the cornea in the channel that was created. And this is showing you now how the cornea flattens. If you notice that center cornea, see how it flattens? That's what I mean by the cone becoming more of a dome. And even the intacts can be done in such a way that we made it an art. You can put it in different directions on the cornea because each one's cone is different. So we'll see that with the patients we have today, how different it looks and how it corrects each one differently.
Okay, and we actually have a patient here today that you brought in, a patient that actually had this surgery. James, if you want to come right up and tell us a little bit about why you chose to have this specific surgery.
I chose to have the surgery on the recommendation of my optometrist. He noticed that my vision would consistently deteriorate every 6 months to a year, and he'd heard of Dr. Glani's procedure and recommended that I go and meet with him. And after our meeting, he discussed everything in detail and what the benefits were, and I was completely sold. And I said, you know, it's only going to get worse, and knowing that it's going to constantly get worse, there had to be something done.
And so describe your experience a little bit. What was the surgery like? Can you feel them? Because when I look at them, it looks like something that you'd be able to feel in your eye, and that would drive me nuts, like knowing that something was in there.
Right. I've had them for over 3 years, and I don't feel a thing. The only thing that I notice different is that when I wake up in the morning, I can actually see the alarm clock, whereas I could not before. But you don't feel them. All you notice is that your vision has improved, and you're confident that your keratoconus will not continue to progress.
And how long had you had keratoconus?
I'm not certain when it started to develop, but I understand it's a hereditary disease of the eye, and I don't think it became really severe until probably my mid to late 20s.
And that's when you really just started
That's
knowing
when I noticed,
it just kept getting worse.
It's starting
and worse
to get
and worse.
progressively worse every year or so.
Had it gotten to the point where you were just fed up with it, that, you know, like my glasses, I've told Dr. Glani before, they're pretty thick.
Well, that's exactly what happened. And you know, you notice that, okay, well, you know, my wife, hers stays pretty much the same all the time. Mine continuously gets worse, and it gets worse, and it gets worse. Not dramatically so, but progressively so. And there had to be some sort of solution out there somewhere, and I trusted my optometrist, and he made the recommendation. And as I said, once I met with Dr. Glani, he explained it in detail, in layman's terms, so that I could understand fully of what I was going to be getting into, what kind of results I could expect. And he didn't make any grandiose promises that he did not come through with. Extremely happy with what the results are.
Recovery, what was that like?
Well, out of it kind of the first day or so, but the recovery, as soon as everything wears off, as far as you know, whatever the slight anesthesia was or whatever, you're in good shape, and you can start seeing right away. And it was, for me, a very, very good experience.
You noticed an immediate change after the surgery. I mean, we've talked about this before with LASIK and all the different other surgeries. Everyone seems to notice pretty much immediately afterwards a change. Was it the same for you, or did it take a little bit?
Well, it just took for the medications to wear off.
Okay.
Well, once those wore off, I think I woke up the second day, and like I said, I just noticed what time it was. And I hadn't put on my glasses yet.
I'm jealous, because there's no way. My alarm clock is right there, and I have to literally like lean over, or else ask my husband, "What time is it?"
And you just notice changes slightly. It's like all of a sudden I notice I'm nearsighted, but bad nearsightedness, and I notice, okay, if I'm reading, I got to take my glasses off. I have to, and that was a pleasant benefit of the surgery.
That's wonderful. Well, thank you so much for joining us. I appreciate it. And Dr. Glani, with these intacts, I mean, you teach eye surgeons all over the world how to do this procedure, and you actually customize, as we've talked before, You customize each of those surgeries for whatever patient. So you even change also with those intacts. You change the size, the thickness, and the depth of, or whatever, thickness of it. Why do you do that, and how does that change the results for each of your patients?
Sure. Thank you so much, James, for being here. The main concept here, Karen, is, again, we've discussed this in many of our previous webinars, which you've had tremendous response to, and we've also talked about this. We're going to talk about this in the future, too. I look at every eye surgery as an art. It's not cookie cutter. So even when you're doing intacts, think about it. Everyone's cone is not central. They may have an inferior cone, a temporal cone, plus the cone height may be different, and in keratoconus, people's corneas actually are thinner than normal. So depending on all these things and the shape that we can get with the three-dimensional testings that we do, I can actually plan where to enter, where to start putting the rings, and even defer the rings. Like you can put a thick ring where the cornea is very thin, and put a thinner ring to counterbalance it. Again, trying to make it as much as a dome as we can. And I think our next patient is an example of this designing of the intact where, like James said, is very important. In intacts, you don't expect vision to change like LASIK like next day. But many of them still do see that improvement. And actually that improvement continues for 6 months. So it's unique. And also James said a very important thing. Anecdotal studies have shown that intacts even decreases the ongoing disease of keratoconus and kind of keeps the cornea more stable for the future of that patient.
There's nothing that actually cures it. Is that correct?
Not yet.
Okay, not yet, but hopefully down the road. Well, Lawrence, why don't you come up and sit up here with us? Now, Lawrence, you had this surgery. Can you explain a little bit about what you did specifically for him?
Yes. So for Lawrence, his keratoconus was what we call asymmetric, meaning the cone is more inferior and temporal. If you look at the cornea in the center, it's more to the side. So that's why he cannot wear contact, or it'll wobble kind of thing. So in his case, we put the rings in such a way that I could literally move his cone more towards the center, make him more central, if you may. So he's now much more dome-shaped curvature. He literally is seeing with his glasses. So coming out of hard contact lenses and inability to see, this goes back to my analogy of an 11 feet tall person looking for a suit. Now he can go and just get glasses and he's fine. We will talk about this later in our webinar of how even that we are taking care of now in the next stage where we can do laser on an intact. But so Larry becomes different from James as many other patients is. You can design how you're entering, what thicknesses you use of each segment, and how you even place it strategically to arrange the architecture.
To, again, change how...
That cone will become a dome.
Okay, perfect. For you, did you go to a number of different doctors and were told that there really you had no hope? Or explain your experience.
Well, with me, it was over the course of 2 years. I was in contact lenses first, and I noticed it kept on shifting and changing my eye vision. And then every 6 months, I would have to get a new prescription. So I finally asked the doctor, I was like, where can we go next? And he says, well, let's do some more detailed research on your eye. And as he was looking, he says, I think you have keratoconus. And I was like, kerato what? And that's why I started going on the web. And I started searching the World Wide Web for keratoconus and all the different options. And I come to find out the best person for keratoconus was here in Jacksonville with us, Dr. Glani. And I went to go see him, and he explained to me what the problem was and how my eye was uniquely different than most keratoconus patients because of a cone-shaped difference.
Did you notice a difference when you were wearing your contacts that they didn't fit correctly?
It was more of inconvenience because I couldn't keep it in my eye. It was actually shifting on my eye, off my eye.
So you'd have to constantly put it back on or
so
move it around.
So it doesn't stay on a dome, so it's kind of on a seesaw.
Yeah. And being in the medical profession and doing presentations at work and everything's like, excuse me, I can go to the bathroom and fix my eye, contact lens.
You can't do that.
No, and it was an inconvenience. And I was looking at the option going back to glasses. But through Dr. Glani, I was able to go to glasses. And my power was reduced from a minus 550 to a minus 3 now.
Wow.
And my vision is so clear now, it's like night and day, the difference.
How long ago did you have the surgery?
I had it last August.
You had it last August. Were you nervous about doing this procedure?
After doing the research on the web and seeing the different options available, I asked Dr. Glani, what about the vitamin shots and the different options I had? He said, Larry, for what you have, the only thing that would work is the intact implants. And I had to space them specifically because of your cone. And after reviewing the surgeries online, and I said, well, this doesn't take too long. He said, oh, in 7 minutes you'll be out. I said, elected to have the surgery. A couple days later, notice I can see my alarm clock again. But over the course of 6 months, it kept on getting sharper and sharper and sharper. And even to the doctor's point, I mean, every time I came in, he was so excited. It's like, Larry, you're seeing clearer and clearer. You're almost 20/20. And with my new glasses now, I am 20/20.
What is your prescription, or what is your, you're 20/20 with your glasses. How about without your glasses?
20/30.
20/30. So that's very,
Pretty
very
much there,
good.
yes.
You're better than me. And I have contacts.
And I was almost legally blind. He was saying, Larry, you're almost blind in your right eye right now. If we let this go any further, it could get worse. So it's a disease that doesn't get better on its own, and it has to be managed in such a way that it is right for you.
And last question for you. Recovery, you know, do you feel those intacts? I mean, again, I'm just surprised that you can't feel anything, because it just looks like you would feel it.
That was the beauty about it, is like, okay, you're actually there having the surgery, and in 7 minutes it's all over, and you feel nothing.
It wasn't even painful during the surgery?
Not even during the surgery. And it's one of those things, is like, you're looking up at him, and he's doing this, and you feel so comfortable, and it's like, oh, it's over? It was that quick. And then for 2 days, you don't feel nothing, and next thing you know, you're seeing clearer. But over time, that's where it really gets, because it gets sharper and sharper, and it's like, the next day is like, okay, what's this day going to be like, the next day? And doing presentations, I do a lot of presentations at work. I can actually see the screens now without having to struggle and squint, and that was really a big beneficiary.
Thank you so much for being here today. I appreciate it. And we've actually had a lot of people write in and ask questions about this keratoconus. For example, we have one question from a patient, or from a man that came up on our Facebook account, and he says that he's had keratoconus for about 4 years, and he has the RGP lenses. And he wants to know, what is the most common practice to accurately fit these lenses for a keratoconus patient?
Sure. The most important thing, does he have a name there?
We will try to find him, I think. John Snipes.
Snipes, okay. So I know you'll have a lot of other questions, and then Facebook, that's unique too, people writing in from there. But John, the important thing here is to determine the level of keratoconus. Like I say to all patients and surgeons all the time, no keratoconus is the same in different people. So get investigated for that, go through a full diagnostic testing in 3-dimension, find out your level of keratoconus, what's your refractive error, meaning do you have higher astigmatism, do you have higher myopia, meaning nearsightedness. Then look at your treatment modalities, glasses and contacts. RGP lenses basically work on you because they are camouflaging your real shape, which is the cone. But RGP lenses are usually uncomfortable in patients like you, especially when their cone is going on progressing. So once you get that checked, you can pretty much look at whether it's the contact or is it your keratoconus that's progressing. And then look at the treatment option, which today there's a new modality also coming in, which we've just investigated abroad, and we were talking about it at the National Academy in Chicago, called C3R or CXR, which is a collagen cross-linking. And that pretty much can stabilize your cone if it's in the earlier stages. Otherwise, you can have intacts of different levels, single segment, multiple segment, and combinations, and even laser combination that we'll see in the next few patients. The other important resourceful sites, of course, you can go to our website. There is a lot of information on keratoconus, but you can also take advantage of National Keratoconus Foundation, which is based in California. A lot of resources there, and Q&As going on. There's a KC Global, London-based. So all these organizations are there to help you interact with other patients, talk to them, and of course you can call or email us anytime. We're happy to help you.
Now, he said that he's interested in getting intacts because those lenses are so uncomfortable.
Correct.
So one of his questions was, if he continues to carry on with this discomfort, what are the repercussions? Because he says in the area where he's living right now, there isn't a Dr. Glani.
Yes, so the repercussions are, again, like I said, if his cone is progressing and he's wearing the contacts on it, he's kind of affecting it. It might end up with a scar. So he has to be careful. First, make sure the cone is not progressing rapidly. Is it just the contacts that are uncomfortable, or is it the cone that's making the contacts uncomfortable? So that has to be evaluated.
So the most important thing, I guess, you're telling him is make sure to go in and at least get it evaluated so you can figure out where the problem is immediately, and because it could be a bad situation if you continue without.
Absolutely. Make sure there's nothing acute going on, then plan for surgery.
Okay, now we also talked about lens-based surgeries for keratoconus patients, surgeries like the ICL and the cataract surgeries. Can you talk about those a little bit?
Surely. like we know the eyeball, and we've discussed this so many times before, keratoconus, the biggest issue here is the cornea is cone-shaped. But so in many cases, if the myopia, or these people are also very nearsighted because the cornea is so cone-shaped, you can correct that extreme nearsightedness, not by LASIK. Remember, LASIK you don't do on keratoconus because you don't want to cut a thin cornea. It will worsen the keratoconus. You can do advanced laser surgery, which we'll talk about later. So in patients like this, you can let the cone be where it is and correct their high nearsightedness by putting in an ICL, or what I call a lens augmentation procedure, where you can put in an artificial lens, it's like a contact lens permanently, on top of their natural lens inside the eye. And that corrects their high nearsightedness, which is a part of keratoconus, and they lead a very perfect life. Now, if in these cases you need further surgery, you can also do intacts in the cornea for conus and put an ICL inside the eye. So here we are coming to our combination discussions. Let's stop for a minute. Since we are talking about the lens in the eye, these keratoconus is also prevalent in patients who have lived their life with keratoconus, and now they're at the age or stage where they have a cataract. Even these patients need to be designed in their surgery so we can have them seeing. For example, we have a Mary here today. You can literally, while doing their cataract, select a lens that corrects not only their cataract, meaning the cloudiness, also corrects their astigmatism. It's called a toric IOL, or toric lens implant. You can put this lens in these eyes and they actually see so well. And we can see that. So my point is, keratoconus at any stage, age of your life can be corrected as long as the surgery is designed, whether it's single or even staged or combined surgeries, to help you see with the best architecture you can, avoiding invasive surgeries like transplants and keeping them as a last resort.
And you have some video of these surgeries?
Yes, absolutely. We can have Mary come up as I put on the...
Mary, why don't you come up and sit with us for a little bit? And with these surgeries now, how long of a surgery is this, for example? I mean, we talked about the other one, 7 to 10 minutes. What is this going to be?
This is like cataract surgery, Mary, so this was about 6 minutes.
6 minutes?
Again, done with drops, numbing drops, and the patient's mildly sedated. It's like cataract surgery. The difference is you're planning it in such a way that you come out with excellent vision despite the cone. That's the whole concept here.
While you're getting that video up, Mary, can you just tell me a little bit about why you chose to go to Dr. Glani? Tell me how you came about finding him.
Okay, well, I've had keratoconus in my eye many years. It developed over many years, and my optometrist, well, actually, then I developed cataracts, and so my optometrist recommended that I should go to Dr. Glani really for cataract surgery, which I did. And so after him examining my eyes thoroughly and evaluating my eyes, he just, of course, saw the keratoconus right away. Decided to use an intact.
Not for you. For you, we did the intraocular surgery.
I mean toric.
Toric
the
lens.
toric lens. Yeah, that was. He decided to do the toric lenses on my eyes, so that's what I had, and cataract surgery.
Wow, so you had a combined surgery. Now, what is this showing us?
This is actually showing Mary's surgery in animation. So it's pretty much like a cataract surgery at this point. The difference is what I like to talk about all the time is how you can design each surgery for unique cases. So this is removing the cataract using high-speed ultrasound. And you can see the cataract disappearing with that simple pencil-like instrument which we go in through without a big incision. And that's the lens being delivered in her eye, done with drops. But the lens is uniquely designed and powered to correct her vision and the astigmatism.
Mary, did it hurt?
Oh, no, not at all. I mean, nothing. Immediately after it was over, we were driving home, I could see well.
You could see immediately?
Immediately. Even in the surgery center, actually. I knew that once it got the cataracts off and got that cloudy look out of my vision, that would be better. But I didn't dream that my vision would be so improved. I just thought I'd get rid of the cataract. But on the way home, I thought everything is greener and brighter and straighter, and I just couldn't believe it. And every day I would find some little something I hadn't been able to see well before that I can see now.
That's amazing.
For instance, following my fingernails. I picked up an emery board the other day, and I expected to do one of these, you know, and I realized, well, I'm just seeing real well to follow my own fingernails.
That's excellent.
And even to read. The reading is much better, much better.
And so it improves your quality of life.
Oh, sure. Yeah, and I've had this for years, put up with it with glasses for years, and the only thing that seemed to be done to help me was just keep changing the lenses in my glasses until finally there was no more change to be made.
Well, thank you very much, Mary, for joining us. I appreciate it. And we talked about, you know, combining all these surgeries, and that's what you're doing. You do combine a lot of surgeries with the intacts, or in her case, the cataract surgery and the toric lens, correct?
Yes.
And then what kind of,
Thank you, Mary.
when you combine all these surgeries, how much does it improve the vision?
When you combine surgeries, there is a reason for that. While we are getting William over, what we talk about is a combination concept. If you see the eye model we have,
Let me get this out
what
for
happens
you.
is you look at the eye, you think about it as a structure where, that's fine, I'll just use one half so we can show
Of course
the
I
audience.
can't keep it together.
So that is actually your normal cornea.
Come on up, William.
William, come on up. You can give me some other cornea pieces from there, okay? So this is a normal eye. I'll just go through the system so this way it will kind of summarize everything we've discussed today. Thank you so much, Karen.
Sorry.
Okay, no, you're fine. It's perfect. So let's just summarize this for the audience who are joining us now. This is a normal eye. In a normal eye, the cornea is dome-shaped. This is what happens to patients with keratoconus. The cornea becomes cone-shaped. So if you see this on the palm of my hand, it becomes very clear what we are showing here. This is a keratoconic cornea.
Yeah, this is coming to a point, and you want it to be
Exactly.
rounded.
So you can imagine a contact can't sit in, plus they're looking through a kaleidoscope. Now, combination surgeries we discussed, for example, in Mary's case, her natural lens in the eye, we took advantage of that being a cataract, and we kind of corrected that lens, which is, everybody knows a cataract is a cloudy lens. So we removed the cloudy lens, put in a special lens inside, which had toricity or astigmatism, and it fixed her. Now, take combination technique, where someone like William, being in the medical profession, he already had intact surgery. Else, I think Maryland, Virginia, if I remember.
Virginia.
Yes. He had it there, and the surgery went well, but it had no good outcomes vision-wise. He had the intact surgery.
Okay.
So what we did in his case is, instead of removing the rings, we did advanced laser surgery on top of it. So we corrected the residual astigmatism that was left behind beyond the intact, and you see him, he's without glasses.
Tell me a little bit. What was your vision like before, and what's it like now?
Well, I used to wear contacts. One morning I woke up and everything was sort of distorted, so I figured I'd put the contacts in the wrong eyes. So I changed them up, still distorted. So I went to the doctor and said, hey, something's wrong here. And after a little while, I had a whole lot of people in the room looking at my eye, and I was like, what's going on? So they told me I had a condition, keratoconus, which I've never heard of, sounded real bad. So I did a little information gathering myself, found out about it. So over the years, they sort of just watched it, and it progressed and got worse. So, you know, one of the doctors told me about this new intact thing. So I went to Virginia, had that done. I was in the military. You know, it got a little better, but not enough for me to really notice anything. So I was seeing an optometrist out in town. He suggested Dr. Glani. He said, if anything can be done for you, this is who you need to see. So I was like, hey, what's the worst I have to lose is my eyesight. So went to see Dr. Glani, and he talked with me and my family, told me what I could expect, and he told me, hey, it's not a lost cause. We can make it better for you. So I was like, okay, I'm willing to try it. And, you know, he set me up for the surgery. I was really apprehensive about it. But once we did the surgery, I was like, wow. I mean, just one day after leaving, I was like, this is really strange, because now I could actually see individual blades of grass, which I was like, I knew this is the grass down here because it's green, but now, I mean, I could actually see bugs in the grass.
Were you surprised you could actually have a different type of surgery even though you had the intact?
Yes, I was real surprised when he told me he could do something else. I was like, well, you know, your eye is only so big and you can only do so much to it. But he was like, he assured me, he said, you know, we can help you. You know, there are ways out there. It's not a lost cause. And I was like, okay, well, let's just see what happens and go for it. And, you know, it was probably one of the best decisions I ever made. And I'm really glad for it, because it changed a lot of things for me.
Thank you so much for being here today, William. I appreciate it. And I think that is important for people to know, is that there is something else that you can do if the intacts don't work, or like in William's case, you need something else done to see perfectly. You can provide that, or those options are out there.
Again, if you approach the eye or the vision as an art, you can always do things to arrange the optics to make people see, yes.
Well, thank you so much. That's about all the time, unfortunately, we have for today. As you can see, a lot of people do have questions about keratoconus. It is something that is out there that people do want to know more. And if you have any questions, you can contact Dr. Gulani directly at 904-296-EYES. The information, of course, is up on our screen, and you can also email your questions to gulanivision@gulani.com. And we will be back here again next month on November 11th at 12:30 p.m. We're going to be talking about surgical options to avoid reading glasses, and that is sure to be a hot topic for a lot of people, because nobody wants to have those glasses. Thank you so much for being here today, and we'll see you next month.